joint field. And granted, this could go in a lot of different directions. And this is sort of what caught my fancy as I was listening to all the talks. So one of the themes that it is important from the surgical point of view is SI joint surgery just for those of us crazy enough to actually care about it? Or is it something every surgeon in the world needs to understand? And as David Polly has said, it's okay to ignore the SI joint if you don't mind being wrong 20% of the time. And I think that's a really good starting point. The next point is that hip and knee surgery works 95% of the time. Spine surgery only works 80% of the time. And is it misdiagnosis or inadequate treatment of SI joint pain that occurs over 20% of cases of low back pain where that discrepancy is occurring? Likewise, can we improve the reliability of SI joint surgery? The point there is that if you look at all those studies, including the best ones done in level 1 trials, there's still a huge variability. And they report standard error, not standard deviation. And the standard deviation really shows a much greater amount of variability. And I don't think any company has really a reliable method of fusing the SI joint. I think at best we're getting 80% improvement. And if you define improvement as greater than 50% in pain, it may be down as low as 50%. So can we get more reliability and more robust improvement? Can we get more patients back to work? We've got a lot of room for improvement going forward. I think we've made great inroads so far, and I think it's pretty clear the field is going somewhere, but I think it'll continue to improve. So why should all spine surgeons understand SI joint surgery, even if they don't want to do it? Spine surgeons are the best prepared to treat surgical low back pain. The SI joint is the foundation of many surgical constructs. Over half of patients that undergo lumbosacral instrumented fusions develop SI joint pain within 5 years. Misdiagnosis causes unnecessary surgery, and there's a complex relationship between deformity and SI joint dysfunction. We need to avoid shooting at the wrong target, even if we don't do SI joint surgery, and all spine surgeons should consider low back pain for multiple different causes, including not just the standards like listhesis, spondylosis, facet pain, but also myofascial pain, SI joint pain, piriformis, ligamentous dorsal recess pain, hip pain, cluneal nerve, gluteus medius and maximus trauma, deformity, and all the other things that get lumped into low back pain, so that we avoid doing unnecessary surgery. So all spine surgeons have to consider the relationship of stenosis, deformity, and adjacent segment failure, among other causes of SI joint pain as well. So a lot of this falls into the spine surgeon's lap. So I think as members of SIMEG, we need to take all this knowledge we're getting at this meeting and make sure our colleagues are interested in SI joint pain, even if they're not operating. The dark side is that there are some deterrents to a mass acceptance of SI joint surgery in terms of people doing it. What are the deterrents? It's pretty straightforward. It takes a huge amount of time. It's very high touch. In Martin Blaze's registry, there was a minimum of 9 office visits. And it would be easy to say, well, the registry is too complicated, but that's sort of what my patients with SI joint look like. It's a very high touch. I lose a fortune taking care of these patients. We all do. The compensation for the time to diagnose them and treat them pre and post-operatively is insufficient. There's not good alignment in terms of that. And the compensation for the operation itself is far below what it should be for the amount of expertise and time compared to other operations we do that are far more well compensated. So we have some of our worst patients that are being ignored because of this problem, which is totally out of the scope of this discussion. There's now about 30 devices cleared for the SI joint space. And the common element is that they all seek to stabilize the SI joint and reduce the stress and strain on the pain generators. But they do this with very different mechanisms and possibly different effectiveness. And as we just heard, the outcomes variability and durability are far underreported for almost every single one of the devices. So we've got a lot of reasons that surgeons need to understand the anatomy really well. There is tremendous variability in the SI joint. And so why we may need a lot of different devices or maybe 3 different device strategies in the armamentarium for every surgeon that does SI joint surgery. There are sacralization changes of L5 and Castelvi changes. There's lumbarization. There's asymmetrical dysplasias. There's a very oblique angled sacroiliac in some cases, making the lateral approach more challenging. There may be a small or irregular SI joint, making the lateral approach more difficult. There could be variable sacral shapes or contours that may affect the posterior medial approach. Degenerative changes, erosions, pseudoarthroses and accessory joints and bone islands may play a factor. There can be a very heterogeneous location for pain generators, as well as heterogeneous and widespread innervation of the SI joint. So what works in some cases may not work in others. There could be gender and age differences. The effect of long adjacent segment constructs with or without deformity may affect the durability of one procedure versus others. The presence of spinal hardware in the operative path may affect whether we use one approach or another. There are challenges with bone density and bone health or the osteoarthritides that may affect our choices, whether we're doing an index operation or a rescue operation or an operation concomitant with other spinal surgery would also affect our choices. So there's a lot of different thought processes that we're all going to have to use going forward, but we need as much knowledge to make these complex decisions as we can get. So I'd like to thank Volker Fuchs and Michael Derricks for their tremendous amount of work organizing this meeting, for all the speakers for their expert contributions, our sponsors for their support, and importantly, I'd like to thank everybody that has chosen to participate in SIMEG. We really need everybody's participation and the growth of the society and the growth of the spine surgery world's understanding of SI joint disease. Thank you.
We should clap. Very good, everyone.
Thank you, everybody.
Volker, thank you. Michael,
Thanks.
thank you.
Thank you, everybody.
Yes, thank you very much. It's been an honor to be elected the next president of the society. I've been involved in this for almost my entire career. And obviously, people who were around at that period of time know we were pariahs. Anybody believed in this or even thought about doing a surgical procedure, oh my God, tarred and feathered. I mean, it was crazy. And to see this evolve to this place is very exciting, especially with the faculty, a lot of academic interaction to help drive this. And we're always here for one reason, it's the patient. You know, that's the reason we're all taking the time off today. That's why we've made this commitment. And despite all the hurdles, I think it's going to continue for that reason. So for that, we look forward to SIMEG's future educational meetings and collaborating with my colleagues.
Thank you, everyone.
Thank you.
Till the next time.
Yeah.
Right. Tom Freeman mentioned that the next meeting we were going to have was going to be Mother's Day, so we'd like to change that. It was bad. Was
We're
on.
not laughing at Valentine's Day. This is not going to work out well.
You're trying to get us all in the hot seat here. So we can start by having a vote or finding a time to have our next meeting. And then from there, the educational programs will be developed. If anybody has any ideas and they'd like to, share that with us, we welcome it.
Okay,
Maybe we could, a little update as I think about it from this International Japanese Sacroiliac Joint Research Institute. That sounds very exciting, and what that might involve and how we could potentially integrate with that and use some of its resources and contribute in that way.
Yes, we have to talk to Dr. Kurosawa, and maybe we can also join both associations, the Japanese organization and SIMEG, and then we have much more members, and or I'm much more confident that we can bring up new issues and solve new issues with a lot of more physicians than we are now.
Dr. Kurosawa, will you be able to give us some, not right now, but at some point, more details about your new research institute and how we could collaborate?
I cannot explain well. In Japanese, engineer for making an Android model with Sacroiliac joint is very interesting. I'd like to share about the Android model to research in near future. Now, we will find the function, a new function of Sacroiliac joint. Sacroiliac joint choose very useful power for bipedal walking. So I will be able to share the new information for Sacroiliac joint biomechanics in the near future.
I appreciate that. Volker, are we good to finish up? It's been a long morning. In fact, we are about an hour and a half over it.
Yes, quite a lot of time over it, yes. So thank you again for joining this conference, now the fourth conference, and I'm happy that we're still there and that we're getting, or that we're growing, and that I can, it was my idea to bring all those surgeons together, and I think it works. It could work better, but I tried to bring it forward and to make our association bigger. And yeah, thank you for being there, and thank you for listening, and hopefully see you the next time.
Great. Thank you, Volker.
Thank you. Bye.